Hello, CTSNet community. We have another special edition roundtable today, this one entitled The Effect of COVID-19 on Cardiothoracic Surgical Education. I'm joined by several leaders and representatives to discuss multiple issues. First, we have Dr. John Potts, Senior Vice President of Surgical Accreditation at the ACGME. Dr. Stephen Yang is well known to the thoracic surgery community. He serves on the American Board of Thoracic Surgery and is currently Professor of Surgery at Johns Hopkins. Dr. Manisha Sudarshan is a thoracic surgeon at the Cleveland Clinic, heavily involved in resident education. Finally, Dr. Andrew Brownlee joins us as the Senior Fellow in Cardiothoracic Surgery at the University of Chicago. Thank you all for joining us.
Thanks for the invitation.
So first, I just want to jump right into the ACGME and congratulate you guys for really emphasizing work hour restrictions and the importance of protecting our trainees and residents despite this pandemic. You've put out multiple notices and letters to the community, and it's definitely appreciated by all the trainees and all the program directors out there. So John, thank you for doing that.
It's unusual for the ACGME to receive congratulations, but we accept that.
So back to you, John. Most institutions are asking attendings to volunteer in our COVID units. We see traveling nurses and locums physicians are being brought in, especially in the New York area, at significantly increased pay. But our trainees don't really have the option to refuse. They go where they're told and they receive their standard resident salary. There's been a lot of discussions on Twitter and in social media about hazard pay and additional benefits for trainee protection. Does the ACGME have a stance on that at this point?
Well, the fact of the matter is that we have no standing in the pay level for a resident or fellow at any time, other than ensuring that the institutions fulfill their contractual obligations to pay those individuals. And that applies during this pandemic as well. If you think about it, surgery residents on a day in, day out basis, year in, year out, face greater hazards in their work than does, let's say, a psychiatry resident. And yet I know of no institution that increases pay to the surgery residents on that basis. Mm-hmm. So we have no standing in it. Like you, we've heard of concerns about this. We've also heard some creative solutions that are being offered by institutions, but it's just not an ACGME issue.
Understood. I think the most important topic we all need to talk about today are the case requirements and our case logs. As everyone can attest to, elective cases have been significantly impacted by COVID. How do we make sure that our trainees are still able to meet their numbers and graduate on time and have the appropriate expertise that they need to graduate? John, jump in.
Well, it's an important question. It's an important question every year, whether we're in a pandemic or not. The decision of whether to graduate a resident or fellow as scheduled is always up to the program director, presumably with input from the CCC. I think it's important to remember that the case minima are just that. They are the floor. But they're the floor for program accreditation. They are not a surrogate for individual ability, individual competence. They are used for program accreditation. So, there are residents and fellows who are ready to graduate before they accomplish all the minima. There are residents and fellows who are not ready to graduate after they've far exceeded the minimum. And it is up to the program director to decide which is which and whether or not an individual should graduate on time as scheduled. The decision to delay graduation for an individual carries a lot of implications for the institution, for the program, and certainly for the individual. And all of those implications are negative, really. On the other hand, The decision to graduate someone before they're truly ready also carries implications for the program. It carries implications for the individual. Most importantly, it carries implications for the public, who we are there to protect as the ACGME. So, that decision to graduate a resident is always, I think, one that a program director should put a lot of thought into. That's particularly true this year, in which the program directors will not have all the information that they would normally have about a given individual. Maybe they haven't accomplished all the case minimum. Maybe they haven't accomplished all the months of surgical training that they're supposed to accomplish. And yet the program director could conceivably graduate them on time.
So I think this will pull you into the conversation a bit, Dr. Yang. If a program director opts to graduate a resident that may not have met all their numbers due to the pandemic, how can we be sure that the ABTS is going to allow them to go for certification?
Well, if I can just take a quick step back.
Yeah.
I think, all the three major educational organizations, the ABTS, the ACGME, and the TSDA have actually come together and have been talking to each other since the pandemic started. And the TSDA has actually an excellent page on the COVID-related documents. And so I encourage anyone who's out there listening, the fellows, the faculty, the program directors who still aren't quite sure what's going on as far as education is concerned, is actually to really look at that website, because it's actually a one-stop shopping for all of the major documents that the three organizations have put together and have talked to each other. And on that website also has the statement from the ABTS, from Dr. Fullerton, to encourage, and this was put out last month, to encourage all of the graduating fellows to actually look seriously at their numbers right now, and also for the program directors to talk with their graduating fellows to look at their numbers and see if there are going to be any shortcomings. And so Dr. Fullerton, our executive director, has invited everybody to email him personally if they feel like if there's going to be any major issues with the numbers. And to date, there's only been actually a handful of emails to Dr. Fullerton, and he feels that we are probably in very good shape considering what's going on. Now, again, it may be region dependent, like New York. So at least for the routine cardiothoracic surgeon, we don't see any major shortcomings with case requirements. I think the area that we are concerned a little bit in is congenital heart surgery, where obviously the numbers are quite short, are quite small. The training time is shorter, and so some of the index cases that you usually get as you're graduating come about during these last 3 to 6 months, which they may not achieve. And so that will have to be dealt on with a case-by-case basis. So, but I think in the cardiothoracic community as a whole, I think we're doing okay. If you're missing one esophagectomy, probably not a big deal. Certainly, we have relaxed the requirements. It's not a formal relaxation, but as I said, Dr. Fullerton himself, just so you know, he himself is handling all of these issues. And if there are any difficult situations, he forwards it on to the credentials committee, which is a small portion of our board.
Great. I think that's the right way to handle it. And Dr. Fullerton taking a personal interest in putting the time into this is remarkable. Andrew, you're in that exact situation. You're about to graduate, and obviously your experience has changed because of the pandemic. What were you doing back in February versus now?
So yeah, back in February, we were very clinically busy, and you know, I had my eye towards spending the next few months operating like crazy and trying to, you know, perfect my skill set, and also just identify any areas that I wanted to work on. So it's tough. I mean, it's obviously a huge change, you know, and I think we're still able to work on operating independently. Unfortunately, it's a significantly reduced service size. I mean, our service right now is almost entirely consults. We're doing about 1 to 2 cases per week. And, you know, that being said, we're slowly ramping up again, as some places are in the United States, but there's no misconception that the volume's going to be back to normal by the end of this academic year. So I think, you know, for me and a lot of other trainees, our vision of tuning and polishing our skill set before entering practice is certainly changing.
I think you put it perfectly. Tuning and polishing, that's really the most important part of your last few months of training, is where you actually get to act like an attending and really take the lead. And that's a worry for many trainees out there. I know you had reached out to other trainees around the country in preparation for this. What are some of the other issues that people are talking about?
Yeah, well, as Dr. Yang said, I think speaking to most senior residents, they're actually okay for case numbers. Some have concerns, and some have reached out to the ABTS. Some senior residents in 2-year traditional programs, you know, I spoke to them a week or 2 ago, and they said that, you know, they would consider extending training in the absolute worst case scenario, but none of them currently have plans to do so at the moment. But, you know, that being said, there's people that I spoke to who said, you know, even if I wanted to extend my training, I wouldn't be able to because of my visa restrictions or my, you know, my responsibilities, my professional responsibilities ongoing. And some of the first and second year residents in traditional programs, people who are sort of in the year prior to finishing, are really concerned about how this is going to affect training, you know, in the coming years, in the year or two. As they, you know, try and learn how to operate and prepare to be finished. I think one of the really interesting things too is there's just a huge variability of training experience right now across the country. You know, some people are doing 8 to 15 cases a day still, while others are doing none, and they're in a COVID unit. But I think on a positive note, a lot of people that I spoke to who are not operating are really missing the OR, and, you know, truly realizing how much they love what they do.
Yeah. So, you know, Dr. Sudarshan, the first year of attendinghood is really a transformative year. It's very important. And especially when you're at an academic center, it's hard enough to, you know, let the fellows and residents take the reins when you're just trying to learn yourself. How has the pandemic affected you out in Cleveland and how you interact with your residents?
So I think as a first-year staff, everyone in their first year of practice has a common goal, whether you're in private or academic setting, and that's to develop quickly, personally, with a wide range and good volume of cases. And certainly this aspect has been affected. For thoracic surgeons, there's been a pause in benign lung and foregut mediastinal cases. And certainly my practice right now is skewed more towards cancer cases and emergency or inpatient consult service at this point. My interaction with the residents or service has case per case. However, overall the volume is definitely affected. Our other policy has been not to involve residents with any COVID positive patients, whether in assessment or whether if they require any procedures done. So they're excluded from that part. But luckily in Cleveland, we have not had that many COVID patients requiring procedures as compared with some other institutions. I think from a first-year staff point, it's hard to prognosticate what this dramatic change in practice or so early on will have in development as a staff surgeon. I think we don't know what to expect because we don't know how the reactivation will be like. And certainly our program now is starting to reactivate and go back to a normal OR procedure. Now, whether we will be especially busy as we play catch up with our postponed cases, in addition to a normal busy pace of clinical work, if that happens, then the overall experience won't change. But if it's a different pathway, then it will. And the other reason it's difficult to gauge what the long-term impact for a junior staff surgeon would be, whether there's a potential second surge of the virus that leads us back to our current clinical situation in terms of a very slow clinical practice landscape. I think the most significant facet that has been impacted in the academic life is academic development during this crucial time. These early years of practice are an important period to develop research interests, to use our national meetings, to present, to network, to form meaningful collaborations with our peers across the nation. And certainly with the cancellation of all these meetings, this has resulted in the loss of these opportunities. And even some accepted presentations have now been canceled or not even given the opportunity to present virtually. So I think people are making the most use of their time in terms of working on manuscripts, and which is the real measure of academic productivity, and trying to get research projects off the ground. It is a new institution for many, and so to use this time to learn about that aspect, and also to focus our efforts on trainee education during this time. The other aspect is the written boards. The oral boards. The written boards were done in December, but the oral boards were scheduled for June, and now they have been pushed over to October. And so it just means that for first-year staff surgeons who practice pure cardiac or pure thoracic surgery, it's very important to keep abreast with the entire range of cardiothoracic surgery knowledge, because all candidates will be more than a year out of training when they sit for their oral boards.
You made a great point about building your academic career in the first couple of years, and actually CTSNet thought that was so important that we had a completely separate roundtable dedicated to that. So to all the viewers out there, I suggest watching that. It was moderated by Dr. Mara Antonoff and was excellent. Dr. Yang, back to you. We were very lucky that we had recent ABTS and also ACGME meetings in the last couple of weeks. What were some of the other important issues that came up at the ABTS meeting?
I think as Manisha said, I think our challenge will be is, since we did push the oral exam back to October, I think not just us, but all of the meetings, I just got off a meeting with the Southern Thoracic, is what if the pandemic restrictions continue into the fall, or as she said, we get a second wave. So I think we all have to think about what are our backup plans in case the exams can't be held orally. So some of that discussion was centered around that. But I think we were all still very positive that we've plateaued. Hopefully things might get back to semi-normal. But again, not a lot of the ABTS policies have changed. We did talk a lot about the case requirements, and this issue with Dr. Fullerton discussing managing every single case did show up. But I would like to sort of point out a little bit of what Manisha and Andrew were talking about. I sort of regard myself sort of as a resident at heart, and those of you who know me, I like being really busy, and I like operating, and I like to run circles around the residents. But this is actually a great time just to be reflective, and like in Andrew's case, yes, you're not operating, but you have all the physical tools. But to get ready for your next career, how are you going to prep to be a great academician? Because this probably won't be the last time this is going to happen. This type of pandemic has occurred every 20, 30 years, where things are shut down, and we have to teach virtually. So we have to be reflective of how are we going to be able to do teaching and education and meetings through these virtual medias. Obviously, we won't totally go to this, but I think preparing how to use all these different forms and trying to be interactive virtually, I think, is a challenge. And also for those who are finishing it, it's also a great time to do all the little things that you can't do in the busy service. Go to clinic, go to the virtual clinic, learn how to do telemedicine, go to all the virtual tumor boards, do all the transition to practice. Learn about how to bill and all the financial issues that you're going to be challenged with in the future. So I think it's a good time. I sort of enjoy, because it's, I get to stay at home. My wife is getting a little upset that I'm here all the time now, but I think it's a great time to be reflective and do all the things that you can't do when you're on a very busy service. To take the time to learn all these different multimedia programs. I'm trying to learn how to, do to be interactive during a video program or a PowerPoint program. I think there's new media that my daughter, who's in IT, is trying to teach me. So I think it's a great time to sort of huddle around and try to figure out how to challenge yourself to teach in the future.
Yeah, I want to emphasize something you said. Andrew, learn how to build before you start practice. It will make things easier next year.
All right, I'll put that on the list.
I think that's a great point, Dr. Yang, that we have to get used to this new virtual education. And I think perhaps a good thing that may come out of this is the collaboration among institutions for resident education. Since now everything is so virtual, it's easy to share. It's a good opportunity for trainees to know each other from other institutions, from faculty, to interact with trainees at other places. And it could potentially be an advantage when applying for fellowship or searching for jobs. So for example, we've never had a virtual journal club, and we're scheduling that in the next 2 days. And we've opened it up across the country just because we can. It's virtual, and it's good to get that participation, and it might be a good spin-off from all that comes from this.
So I'll let you give a shout out. If people want to jump on that, how do they find the information for it?
They send an email, and it's on my Twitter account, or they can just send me an email, and I'll send them the code.
Great.
Thanks.
Yeah, of course.
Yeah, another thing is that I know this isn't the goal of this forum, but I think it does point a little bit to our mentorship. Just sort of theoretically, looking at some journal articles from China and from Europe, college students are now rethinking whether they want to go into a medical career. And because of all this, they don't want to have this exposure. But I think we as surgeons, especially those of us who have access to medical students and to undergraduates, is still stress that this is still a great career, that we aren't directly affected by this, but the med students right now who are looking into surgery, especially the students who are looking for I6 programs, really need some guidance and mentorship at this time, because we have to come up with some creative ways. We're thinking about this at the ACS level. I'm chair of the Medical Student Education Committee for the ACS, and we're not to be self-serving. We have a program in about 2 weeks. How do we change the landscape for the medical students looking at surgical programs? And I think right now, those of us at this table can reach out, to those surgery interest groups and say, there's a couple options. There's not going to be any mandate nationally from the ACS or the program directors, but find creative ways to keep these students interested in surgery, keep them interested in CT surgery, because this is the critical time that the I6 students really wanted to stand out and they can't. So reach out to them at your own program to say, keep interested, or we can do some of these projects while things relax, or talk with your surgery interest groups and make sure that we maintain the interest in the medical students for surgery. So we can also do a lot of mentorship during this time.
Yeah, I completely agree. Speaking as somebody in one of the hot zones, I can definitely attest to the fact that education, especially for those that are in undergrad and med students, is really being pushed aside a little bit as everyone's just trying to get through day to day. But now is an important time to continue our mentorship for those exact reasons. John, you had the recent ACGME meeting. Any other issues that came up that you'd like to share or address?
Well, I think you're speaking directly to the review committee for thoracic surgery. Is that correct?
Yeah.
Yeah. There was a meeting recently, and I'm going to rely again on Dr. Yang to help fill in any gaps. One of the other hats he wears is that he's an incoming review committee member. So although he's not officially a member yet, he joined in the meeting just recently. The meeting was held remotely, as you'd expect. The focus really was on accomplishing the absolutely necessary work of program accreditation. So that's where most of the time was spent. There was some time spent doing a little bit of finished work on the proposed changes in the program requirements. I can't tell you what those changes were that were discussed because I mean, I guess I could tell you what was discussed, but the issue is that until they're acted upon by the ACGME Board of Directors, they're not real. And so I wouldn't want to confuse anybody by disclosing what the RC talked about. There really wasn't a lot of time for other discussion. For instance, there was not a lot of discussion about how programs are going to be accredited next year, given case log deficiencies, time deficiencies, and so forth and so on. I think in large part because we just don't yet know what the effect is going to be.
Okay, great.
Steve, did I miss anything important?
I think you hit the highlights. I mean, there was a lot of little modifications to some of the rules, but again, since this pandemic is still very fluid, but at this point, the ACGME, John's letter came out, Dave Fullerton's letter came out. I think things were already set, and as I said, I don't think from an RRC standpoint and the ABTS standpoint that we're going to be too concerned about the case volumes. And I think from what Andrew said is hearing, people are feeling pretty good. David said that he thinks everyone's getting a good operative experience despite these last 3 months in May. So it's more, quantitatively, I think we're fine. It's just the qualitative part, I think, we're not still sure about.
Sure. So for the sake of time, I think we should try to wrap this up. Does anyone have any other topics or issues they'd like to address while we have everyone together and the CTSNet community watching? No?
Well, I have not seen what's on the TSDA site, but I will say that the ACGME does have a lot of guidance out there, both general for all programs, but also specific to surgical programs. So if program directors have not looked at that, I really think they should, either on the ACGME side or the TSDA side.
Yeah, I agree. I'm on it. Go ahead. Sorry, Dr.
Yeah, there are a lot of COVID related articles. Elsevier has about, I think, 30 or 40 papers in print. They're mostly clinically oriented. But I think for the audience out there about education, certainly specifically for thoracic surgery, the TSDA website is probably the best source that I've seen. It has every link there. It does link everything back to the ACGME. Actually, so the residents and program directors who are worried about what are they supposed to report, again, the milestones, the program directors don't have to report it these 6 months. I think the residents are still required to turn in their surveys, but some of the rules and regulations from a program standpoint have been relaxed a bit. And just while I remember the milestones 2.0, so the ACGME had a separate subcommittee about milestones 2 and revision. Those revisions were done. Brian was there. And those revisions are done, but we decided to wait till next year to roll them out because we just thought it was going to be too much education and too much information at this time point to focus on them. So Milestones 2.0 will roll out July of 2021.
All right, on that
I wanted
note,
to say,
oh, go ahead.
just, as surgeon educators and trainees are pushed to harness technology in resident education, I think it might pave the way for more multi-institutional collaboration when it comes to surgical education, and possibly a more unified virtual curriculum when it comes to the next generation of thoracic surgeons.
Yeah, I think this experience has shown us that we could do a lot more virtually than we thought, and it will benefit us actually in the long run. So on that note, I want to thank all of you for participating, Dr. Brownlee, Dr. Yang, Dr. Sudarshan, Dr. Potts. I know the community really appreciates it. To everyone out there watching, stay safe, and this will all end soon, and we'll be back to normal. Take care.
Okay,
Thank
thanks,
you.
Brian.
Thank you.
Bye.
Thanks, Brian. Take care.